Okay, so here we are now working on chapter 6, which is Autism Spectrum Disorder and Childhood Onset Schizophrenia. So I want to be really clear that these are two distinct disorders. However, they are covered in the same chapter of your textbook, which is why I'm covering them both together as well. And part of why they are covered together in the book is because in the past, they were thought to be the same diagnosis. We now know more. We now know that, in fact, autism spectrum disorder and childhood onset schizophrenia are different things with different treatment aims and with different prognoses and expectations. But in the past, the behaviors that we saw with a child with autism or autistic disorder, because that's what it used to be called, were quite similar to those of childhood onset schizophrenia. So that's why they are in here together. We're going to start with autism spectrum disorder, spend a little time on that, and then we will move on at the end and talk about childhood onset schizophrenia. Okay. Autism or autism spectrum disorder is a complex neurodevelopmental disorder characterized by abnormalities in social communication and unusual behavior and interests. Okay. Autism spectrum is pervasive, and what I mean by pervasive is it impacts all aspects of a child's functioning. It's not that they're just experiencing autism at school. It's not that they're only experiencing autism at soccer. It is something that is with them all the time. Some of our other disorders aren't quite as all-encompassing or pervasive. A child with a specific learning disorder will struggle in school, and they may have some aspects of having difficulty in other aspects. So a child who can't read, for example, or can't read well, or can't understand what they've read, might have trouble reading the rules of a game. If they're playing a game with friends, they just got a new game, they have to figure it out. But if an adult reads the rules to them, or their friend reads the rules, they may very well understand it and then be able to play with no problem. The child on the autism spectrum may not have that same ability to switch gears, right? It's something that's always with them in all aspects of their life. So that's one thing to consider. In terms of just thinking about the history of it a little bit, it was the term autism to describe this set of behaviors and this disorder was only 1943, Dr. Leo Kanner. So it's not that old a disorder. I mean, again, remember, psychology as a discipline has only been around, or named psychology as a discipline, since 1879, right? Wilhelm Wundt in the lab in Leipzig, Germany. So we're still a fairly young field, so it shouldn't be that surprising. And you might be thinking, well, so did people not have autism before 1943? No, they did, but they were diagnosed with schizophrenia or another disorder, right? So understand that these behaviors, this constellation of symptoms and behaviors, has been around for a long time. It just didn't have a name until 1943. The other person worth mentioning is Dr. Hans Asperger. And you might be thinking, Asperger, I've heard of that before. Right, because Asperger syndrome was named by him all of a year later. The reason I want to highlight this is because there is no longer a diagnostic description of Asperger syndrome. Asperger syndrome was removed from the DSM when we shifted to DSM-5. And we will, in discussion, we will definitely talk about that, and I will talk about it a little bit today as well. Now, Dr. Kanner, the person who coined the term autism to describe the disorder, he also did a couple of things that weren't as helpful for the field, if you will. He described the parents of a child with autism as being refrigerator parents. Cold, mechanical, and detached. And that might be part of the reason that people today dread hearing the term autism as a descriptor of their child, because they think, oh my God, right? We go back to Freud and how it's all the mother's fault because she was this cold, mechanical, detached mother. No. Just because Leo Kanner said it in 1943 doesn't make it true. Okay? We know that a parent's parenting style is not what causes a child to have autism or to be diagnosed on the autism spectrum. So I just want to be really clear about that, and that's part of why I bring these men up, just to give you some context as we talk about the disorder. So we're going to take see, I forgot my last point. So Asperger's syndrome or Asperger's disorder was a milder form of the disorder, and we'll talk a little bit about what that looks like coming up. So the diagnostic criteria are in table 6.1 on page 159 of the 6th edition of the textbook, page 158 of the 7th edition of the book. And the big thing that I want to draw your attention to is that there are 2 symptom domains. The first is social communication and interaction. And that's one of the things that we see and part of how we diagnose autism, or we start having the hunch that someone might have autism or be on the autism spectrum, is because of the way they communicate with others or don't communicate with others, as well as that pattern of social interaction. And in order to be diagnosed on the autism spectrum, someone has to exhibit 3 symptoms of social communication and social interaction difficulty. And so I'm just going to flip over to the textbook for a second. There's a reason that I schlepped it in with me today. Because normally in class, this is what I would be doing as well. So giving you some examples of these social communication and social interaction difficulties, or the symptoms that we look for. And again, these examples are illustrative, not exhaustive. So that's in the DSM criteria. So deficits in social emotional reciprocity, ranging, for example, from abnormal social approach and failure of normal back and forth conversation, to reduced sharing of interests, emotions, or affect, to failure to initiate or respond to social interactions. So, child's at school, another kid says, "Hey, do you want to play?" Child just sits there, doesn't respond. That's not what we expect, right? We would expect if another child approaches a child and says, "Hey, do you want to play?" the child would say, "Oh yeah, sure, thanks," or "No, go away," right? Either of those would actually be more appropriate than just not responding. So that's what I mean in terms of some of that sort of, it's different, right? The way they communicate, the way they respond, the way they interact with others is different from what we would expect. All children are rude sometimes, right? The "no, go away" isn't a terribly lovely response, but we would expect that of a neurotypical child if they didn't want to play. Another symptom is deficits in nonverbal communicative behaviors used for social interaction. So things like abnormalities in eye contact or body language deficits. And that's one of the early screening symptoms that parents will tell their family doctor, or doctors will ask parents when children are around 1.5 to even up to 3 and say, like, when you're talking to your child, do they make eye contact with you? And that's something that's a little tricky, because I know certainly as a parent, and this happens more now than when my child was young, but if she's done something wrong, she does not want to make eye contact with me, right? And that's often her tell that she has done something wrong, because I'll be like, "Can you come over here for a second?" She walks over with her head down, and I'm like, "Can you look at me?" And she looks up and then looks back down, because she's like, "I do not want to make eye contact with you because you're about to get very, very upset with what I have done. And I know I did bad." A child on the autism spectrum is just not making eye contact in general, right? Most children, when you call their name, they orient to you, they turn towards you, they look at you. A child on the autism spectrum may not do that. So that's another social communication and social interaction sign. And then as well, deficits in developing, maintaining, and understanding relationships, ranging, for example, from difficulties adjusting behavior to suit various social contexts, to difficulties in sharing imaginative play or in making friends, to an absence of interest in peers. And so again, as we think about those different signs, we have to consider the context. So a child who has never been to school before, a child who has been staying at home with a parent or a caregiver from birth up until the age of 5. And maybe they've gone to the occasional program where other people were present, but they weren't really interacting with other people. their first day of school, they may not be so gung-ho on interacting with other people. They may keep to themselves. They may prefer to play by themselves. That does not mean they have autism spectrum. It means they haven't had exposure and opportunity to do that. If 3 months into school, they were still walking into school and sitting by themselves and not interacting with anybody else and not playing with other children and not speaking to other children, well, then I might get curious. Okay, so we have to consider the context always. Whenever we're dealing with children or adults, we always want to consider the social context and the cultural context before we jump to a diagnosis. So the second point is this restricted repetitive patterns of behaviors, interests, or activities. Children with autism or on the autism spectrum really thrive on routine, but to the point where if you break routine, it can be significantly problematic for them. So this is how they like things. If they like to have 7 blueberries at breakfast and you decide, well, the blueberries are kind of small, I'm just going to put 9 on their plate, no. Okay, that's going to be a fit. You're going to be like, it was 2 extra blueberries, just don't eat them. And for a neurotypical child, that's exactly what you would say if they said, why are there more blueberries than I'm used to? You'd say, oh, they were small. If you don't want them all, don't eat them. And the child would go, okay. For the child on the autism spectrum, those 2 extra blueberries upset their whole day because they wanted 7 blueberries, not 9. They don't care about the size of the blueberries. They care about the number of blueberries, okay? They also tend to have very restricted interests. You will have a child with autism who knows more than your average undergraduate paleontology student about dinosaurs. They can tell you what era, what they ate, what their footprint looked like, how big they were, what colors they tended to be, everything imaginable. But if you ask them what season it currently is, they're not really sure. Okay, so a lot of very specific knowledge, and they will want everything to do with dinosaurs and nothing to do with anything else. Okay, so that's some of what we see going on there. And again, they need to have 2 symptoms of restricted repetitive patterns of behavior, interests, or activities for a diagnosis. Now, the changes in DSM-5 from DSM-4-TR were that there used to be 3 domains. Social communication and social interaction were separate domains, and they've now been collapsed together. So that's one change. And then the elimination of all the subtypes of what used to be called autistic disorder and also of other pervasive developmental disorders. So the emphasis right now is on it being a spectrum disorder. One of the challenges is that some people who had a diagnosis of Asperger's with DSM-4-TR no longer meet the diagnostic criteria for autism spectrum disorder. Because oftentimes with Asperger's, we see that social communication and social interaction awkwardness, but we don't always see the behavior piece. So they might not meet diagnostic criteria. And this leads me to reflection question number 1 for you. Do you think it makes sense to merge the DSM-4-TR diagnoses of autistic disorder, Asperger's syndrome, pervasive developmental disorder, and childhood disintegrative disorder into the umbrella diagnosis of autism spectrum disorder? Why or why not? I haven't talked yet about childhood disintegrative disorder, but essentially in childhood disintegrative disorder, the child develops normally for about the first 2 years of life and then starts to regress till they get back to an infantile state. Okay? That's no longer a diagnosis on its own. It's now subsumed under the autism spectrum disorder umbrella. So go ahead and take a moment and then come back. So here we are. You're back. You've thought about that. Let's talk a little bit about these defining features of autism spectrum disorder. So the symptoms, abilities, and characteristics are expressed in many different combinations and in any degree of severity. And so the DSM as a whole is pretty much a categorical document, right? Most disorders, it's do you have this symptom, yes or no? Do you then have 5 of the 9 listed symptoms, yes or no? If you have at least 5 of the 9 listed symptoms, Have they been happening for this period of time? Yes or no? If yes, are they causing you distress or impairment? Yes, here's your diagnosis, okay? There was a push in the development of DSM-5 to start moving to more of a spectrum-based idea where we look a little bit more at the big picture and we also then are able to specify whether a person has a mild, moderate, or severe level of the disorder, as that would help us determine interventions. So 2 people who meet the same diagnostic criteria for depression, let's say, might have profoundly different experiences with their depression and need profoundly different treatment. But all we know when we get a diagnosis as a clinician is the person has major depressive disorder. So how do we know where to go next? Well, that's when we have to interview them and find out what their symptoms are, et cetera, et cetera. The thought was that by moving to more of a spectrum and by indicating severity, that might help us better determine what levels of support someone would need. There are definitely some pluses and minuses to this system, but it has taken some getting used to for clinicians and diagnosticians. Some of the aspects to consider are the level of intellectual ability. So there's quite a bit of overlap in what we see in terms of behaviors and symptoms of intellectual disability and autism spectrum. So we definitely want to consider the level of intellectual ability to determine which would be the better fit as a diagnosis for the child. We want to look at the severity of their language problems. So is it something that can be overcome with some extra help? Is it that they might need to consult a speech-language pathologist or an occupational therapist? Or is it a learning disorder in language, right? All these different things that we have to consider. We also want to be aware that some of the behaviors are going to change with age. So with some other disorders, we see things sort of stay roughly how they are. Someone with intellectual disability doesn't suddenly score 10 points higher on an IQ test when they're 17. But with autism spectrum, we might see some of those behaviors changing with age. Okay, that was the end of that slide. Look at that. Didn't even know that was happening. It's okay, we're good to move on, so let's move on. Let's talk about the prevalence and the course of autism spectrum. And this is also something we'll probably talk about in discussion because it's a little controversial. The prevalence is roughly 1 to 2% of children, and we do see that autism spectrum is 4 to 5 times more common in boys. So there's a couple of things that we have to question about this. Number one, it seems like, if you believe what you read in the media and popular press and all that, that we have so many more people diagnosed with autism than we used to. And that's partially correct. We have seen a higher prevalence of autism in the last 15, 20 years, but it's not that suddenly there are more people showing signs of autism, it's that we're better at diagnosing it, we're better at detecting it, we're better at offering supports for it. Okay, so that's a piece right there. And also, if we think back to what Dr. Canner said, would you want to take your child to be assessed for autism if you were going to be called a refrigerator mother and be accused of being detached, mechanical, and cold towards your child? Of course not. So that's a change. Are there other factors at play? Absolutely, okay? But it's not like there is this sudden surge in autism that really represents something significantly different from what was there before. Is there an increase? Yes. Is it massive and earth-shattering? No. The other thing is this piece about it being 4 to 5 times more common in boys. Is it really? Or is it just that we see the behaviors more in boys? And that's always a question that we have because of the way girls and boys, number one, are socialized differently and what our expectations are, right? Because one of the things we'll find with some of the disorders is that we'll find that when girls do have it, often it's more severe. Well, is that just that we're only diagnosing the more severe cases in girls because the other cases we're just sort of allowing for, well, that's how a girl behaves? So that's a piece. We typically think of girls as being better at social interaction than boys. And in fact, they're often socialized that way, right? Boys are allowed to play and run and roughhouse, girls are expected to sit and talk. So we sort of set them up a little bit that way. And so it would make sense that a more severe social problem for a girl would get our attention Does that kind of make sense to you? I hope so. Okay. So we just have to be aware of that. Age of onset, diagnosis usually happens in preschool, but the onset and often the parental suspicion is earlier. Now that's something else that's changing. We actually now can start diagnosing at a younger age. Even if it's not a formal diagnosis, we can see enough clues or enough symptoms that suggest that the later diagnosis will be autism, particularly if it's before a child is verbal. But that's part of, like I was saying, part of some of those questions. Like when we think about children hitting their milestones, by about, a year and a half, 2 years, they should have X number of words. If they don't, that's a red flag for autism spectrum. If the child consistently doesn't make eye contact or the child consistently shies away from hugs, that's another potential sign. But potential sign, let's remember that. So again, it's a good thing my daughter is only 5 and won't be watching this anytime soon, because I'm going to use an example from my own life. So my child is neurotypical as far as we understand. She seems to be doing just fine. And she very much will come to me for her hugs and kisses and not her father. Because he has a beard and it's scratchy. And that's what she always says. She's like, no kisses, Daddy. You scratch. She has very sensitive, delicate skin, and she does not like the feeling of a scratchy beard. Same thing with my dad has a beard, and she'll be like, no, Zadie, no kisses, because she doesn't like the feeling of a scratchy beard on her soft, delicate skin. That's different than shying away from affection on a regular basis, right? So she comes to me for the physical affection, and she goes to her dad for extra TV time. That's pretty much the way that balances out, right? He's like, well, if I can't show you love through hugs and kisses, let me show you love through Netflix, my child. Okay, that's another sign of pandemic parenting, people. This is, my husband and I were on the same page about screen time, and then March 2020 arrived. And it actually got to a point where when we were both like working frantically in the spring, where she was spending just that much time watching TV some days that at the dinner table, instead of saying, how was your day, I would say, so what happened around Adventure Bay today? Because I knew she was hanging out with the pups of the Paw Patrol for 2 or 3 hours. And she would tell me, so at least she was retaining something, right? So we want to be careful about the assumptions we make. And again, that's where context is so important. If a child is shying away from hugs from everybody, is not making eye contact with anybody, well then my autism spectrum radar is going off a little more than if it's just one person who they don't like. Children are really fussy about things. They might have a family member who they perceive has terrible body odor, so they don't want to go near that person, but they're fine going near other people. Again, that's going to be part of it. The reason diagnosis often happens in preschool is because that's the first time for a lot of children that they are in a semi-structured environment, and there's also other children of the same developmental level and age that we're measuring them up against. A lot of parents, particularly with firstborn children, let a lot of things slide because they don't know any better. Kids don't come with instruction manuals. God, it would be so much easier if they did, but they do not. And if you say, but like if you go to Indigo or Chapters, there's like a ton of parenting books. You're absolutely right. And if you pull 5 at random, they will give you completely conflicting information about what you should be doing to raise your child. Because ultimately, every child has different needs and will demand what they need from the environment once they figure it out. So in preschool, when we now have to sit quietly sometimes, we have to take our turn, we have to share toys, we have to play with different things. We can't just be focused on dinosaurs all day, unless they're at preschool in Drumheller, I guess, because I would imagine in Drumheller there's a much stronger dinosaur component than we have here in Calgary. That's when we start seeing it. We see the social interaction. So again, we have that allowance for, well, this is new for the kids, meeting new people for the first time, but after a couple of months, if they haven't warmed up, if they haven't started interacting more, we start thinking autism spectrum. Okay. In terms of the course and outcome, there's a lot of variability here. Some people are going to have relatively mild symptoms and behaviors. They need just that little bit of extra support throughout their life. Other people are going to go up and down. There's going to be different points in their life where their capacity is just not enough for what the challenge in front of them are. And there might be times where they need more support and more assistance. And the same is true of outcome. I wish I could say that a child who's diagnosed with autism spectrum disorder, this is what it's going to look like. I can't, even with different treatments. There's so much we don't know about autism spectrum, and I think that's what often makes it a bit of a scary diagnosis for people, because it's not as clear. With depression, we know what that's probably going to look like. We know what different treatments are going to do. With autism spectrum, there is so much variability that we just don't have those answers or the confidence to have those answers. The other thing is the causes of autism are largely unknown. So we don't know how to stop it or how to mitigate against it because we don't know what causes it. There was an interesting study several years ago that actually, and the reason I'm going to highlight this is because most studies highlight how mothers screw up their children. Because it's, and a lot of it is like even pre-pregnancy, right? So if you're not eating the right foods, if you're not taking the right vitamins, if during your pregnancy you don't do X, Y, Z and stand on your head 4 times a day, but only on days of the week that have an S in them, right? Like you might be screwing up your child. And dads, well, like they just do their thing and walk away, right? That's just how that works. But there was a study that actually found that men over the age of 50 were more likely to father children with autism than other ages. And for years and years and years and years, women have heard about this biological clock that's ticking and, you know, your eggs have an expiry date. Well, so does sperm apparently. Okay, sperm does get, the quality of the sperm suffers a little bit as a man ages. And so there have been studies that have found that men over 50 are more likely to have children with autism spectrum disorder. So there you go. Just trying to equal out the playing field there a little bit. Not always blame mom, okay? In terms of treatment, I think it's really important to start by saying that there is no one treatment, okay? Because, what do I have written down here? Oh, many try many different things. And because there's no one cause for autism spectrum, it makes it a lot harder to zero in on a treatment or a magic bullet that's going to work for everybody. So each child will respond differently, and we'll also be using, most likely, a variety of different types of treatment interventions. So it won't just be a psychologist. We will have an occupational therapist involved. We will have a speech-language pathologist involved. We may have a family therapist involved to help the family work with the child with autism. We might involve pet therapy. Okay, there's all sorts of different things that are going to happen. But in the initial stages of treatment, the most important thing that we can do is build rapport with the child and get them ready to learn some of these things, okay, to learn some of the new skills that they're going to need. The next thing we want to do is we really want to work on reducing that disruptive behavior. So sometimes children on the autism spectrum, when they get frustrated, they're going to hit another child or punch or act out. Whereas another child might go and sulk in the corner when they're feeling frustrated. The child with autism might have some disruptive behavior. So we want to work on reducing that disruptive behavior, teach the child that there are other ways to deal with their frustration. And for this, we're going to use basic operational conditioning, right? We're going to work on extinguishing the behavior we don't want by not responding to it, and we're going to positively reinforce the behaviors that we do want in the hope of increasing the positive behaviors, reducing the disruptive behaviors. Then we're going to work on teaching appropriate social behavior. Okay, so how do you interact with others? How do you do turn taking, right? How do you show an interest in someone else? And so for this, we use lots of rewards. And there's actually been some success in group work with this, having children who are neurotypical and children who are on the autism spectrum, where the thought is the children who are neurotypical are able to model and help the child with autism learn how to have those social interactions. Because the thought is if you take a whole bunch of children who don't really know how to socially interact and you want them to interact together, you're not really going to get where you need to go. But by having children who do show the type of social interaction you want to see, model, and then practice with children who are lacking it, we see some growth. We're also going to work on teaching appropriate communication skills, and this might involve some teaching of language, right? So we, again, thinking about what the child has been exposed to already, what they're familiar with, what language they speak at home. So they may need to actually learn some more language and how to use it appropriately. And then we're also going to have executive function intervention. And when we're talking about that, we're talking about things like using cognitive behavioral therapy to help a child or an adolescent set some goals and actually make progress towards their goals. And also things like planning. And I had already talked about how important routine was for children with autism. We're going to now work with them on developing some flexibility. That, you know, maybe instead of counting blueberries, we can get a little kitchen scale and the child has 32 grams of blueberries every day. But if it's 31 or 33, that's okay too, right? So starting to build in little bits of flexibility and doing things differently. The key with autism spectrum is early intervention. The earlier we can start intervening, the more likelihood of success we're going to have and be setting the child up for longer term success. It would be much better to learn how to interact socially with your peers at the age of 4 or 5 than at the age of 13, right? So we want to intervene as early as we can. We know that kids are more flexible early on, and it tends to be a very comprehensive and extensive early intervention. But that also is at younger ages, that's when children would have more time for that as well, right? Because you also don't want to be in school and being pulled out on Monday for an hour of occupational therapy and pulled out on Tuesday for an hour of speech language pathology. And on Wednesdays, you have 2 hours of group therapy. It's like, but I'm in school. I have all these other things. So at younger ages, it's easier to do some of that. We also can use some medications, but I want to make it very clear that medications for autism spectrum do not treat autism spectrum per se. They treat the behaviors and any other symptoms that could be there. So we know that kids who are on the autism spectrum sometimes also have a comorbid diagnosis of ADHD. Using medication to treat ADHD may help us get some of the other symptoms of autism spectrum under some level of control, or at least be less problematic because the ADHD is under control. Similarly, the children who act out, who are aggressive towards other people, using some medication that will help reduce some of those outbursts can help, but it doesn't treat the autism per se, it treats the symptoms and the behaviors. Okay? Now, I want to also talk about another type of treatment that is a little controversial. It's called dolphin-assisted therapy. And so what I want you to do first is I want you to click over here, CTV. So this was an episode of W5, which is CTV's like news magazine show. And it's about a family from Montreal who has a daughter with fairly severe autism. And they were given the opportunity to go to Curacao for 2 weeks for intensive dolphin-assisted therapy. And you might be thinking, like, Carrie, what do you do in your spare time to find these things, right? Like, how do you find these obscure videos? And I found this mainly because I know the family in the video. So the mom, Wendy, and I went to university together. And so I have here my permission from Wendy, A, to disclose that I know her and that she's comfortable with me sharing this in my class. So again, just because you find something on the internet doesn't mean you're just like, ooh, I'm going to show that. And especially for me, because there is the personal connection, I felt it was really important to let her know that I was going to do it. And so what she said, so I asked her if it's okay that I show it, and also whether you're okay with me disclosing that we went to Concordia together. And if yes, I'm sure my students will ask how Alex is doing today, as they always do. Would you like to offer a brief update? And so her reply was, hi, of course, I have no secrets and you helped me pass psychology. We are bonded for life. So there you go. So you'll watch Wendy and her daughter Alex, as well as her husband Peter and son Max, as they go to Curacao. And then after you've watched that, I have a couple of links with some other information. So The first is just an article that was on the CTV News website talking about it, and then information about the school itself, or the Dolphin Therapy Center, and then information about Summit School. That's actually the school that Alex goes to in Montreal. And just to give you the little update, she's actually doing really well there. Her verbal abilities have increased to the point that they now describe her as mildly verbal, where she was nonverbal before. So that's it. And Wendy's parting words to me is, my story is yours. So take a watch, and then when you come on back, the first thing you're going to see is a reflection question. If you were Alex's parents, so if you were Peter and Wendy, would you be saving money to go back to Curacao for another session of dolphin-assisted therapy? And please explain your reasoning. Again, 1 paragraph, 6 sentences. Okay, so we're going to move on now from autism, and we're going to talk about childhood onset schizophrenia. Early onset or childhood onset schizophrenia is a progressive neurodevelopmental disorder that causes significant distress and disability. It is quite rare and often more severe with worse long-term outcomes. So if you are diagnosed with schizophrenia in childhood, you will likely have a worse long-term outcome than somebody who's diagnosed with schizophrenia in adulthood. What's interesting is there is no separate diagnostic criteria for children in the DSM. You apply the same diagnostic criteria for schizophrenia. So what you learned back in 2285, so in Intro to Abnormal, we apply that same diagnostic criteria for children and adults. However, we know that children are more likely to present with hallucinations, with thought disorder, and flat affect, and less likely to present with delusions. Okay. So, diagnostic criteria in your text, table 6.2, 6th edition, page 188, 7th edition, page 177, or 187, excuse me. So again, we have the presence of the positive symptoms, so hallucinations, delusions, thought disorder. We have the presence of the negative symptoms, so those are the things taken away from the regular experience. So that can be that flat affect, lack of speech, lack of ability to care for oneself, that anhedonia, that sort of feeling blah, right? That kind of nothingness. But a complicating factor is that children are very creative and imaginative. So part of what we have as a problem here is the idea of imaginary friends. Now, normally in class right now, I'd ask how many of you had an imaginary friend when you were little? And nobody would raise their hands at first. And then I'd say, come on, I'm sure some of you did. And then a couple of hands will start going up, and we'll talk a little bit about your imaginary friends. It is perfectly normal for children to have imaginary friends. It's often in younger children. As the children grow up and start making other friends, the imaginary friend falls to the wayside. But the imaginary friend is almost like an imaginary security blanket that the child gets to take around with them everywhere, and they feel safe and secure, and it's all good. But how do we know when it's a hallucination and not an imaginary friend? Right? So some of you, whether you had an imaginary friend or not, you may have a sibling, a cousin, a child that you babysat for who had an imaginary friend, and you one day were over visiting or somehow interacting with that child, and you went to sit down on the couch, and they said, no, you're about to sit on, insert imaginary friend's name here. And you playing along with her like, oh, I'm so sorry, I didn't notice you sitting here. Would you mind to just scooch over so I can sit down? Or, you know what, I'll go sit on that chair over there, right? So we buy into it and we play into it with children because we get that it's important for them. But what if they actually see someone there? Right? We assume most of the time that they don't, but we don't know. And same thing with some of that like thought disorder and the loose associations that we see. So an adult with schizophrenia would start telling us a story and take 17 side tracks before they get to their point. Well, that's everyday conversation with young children, right? I ask my daughter about her day, and I hear about 42 things that have nothing to do with her day before I hear that her day was actually good. So the communication style of children and the presence of imaginary friends makes it quite difficult for us to render an accurate diagnosis of schizophrenia in a child. So we are looking for those positive symptoms, like I said, the hallucinations, which are going to be more likely than delusions, and also those negative symptoms. So the missing elements, the decrease in motivation, in thinking, in speech, in people skills. So this leads us to reflection question number 3. I don't know why I put a question mark up there. Anyway, how do you think you would be able to differentiate a child's imaginary friend from a child's hallucination? Notice I talked about how do you do it, but I didn't actually say how to do it. So tell me briefly how you think you would do that, and then come on back. Okay, you're back. We're going to talk about some of the precursors and comorbidities. So remember that with a diagnosis of schizophrenia, the person has typically been showing signs for several months before having the active psychotic episode, right? We talk about that prodromal phase, that a person has to be having the active psychotic episode for about a month. But if we look at the preceding 5 months, we will see that there were signs there that we just couldn't connect the dots on, okay? So we know that schizophrenia tends to be a gradual onset, so that's that precursor prodromal phase. We also know that children with schizophrenia may have some intelligence deficits. Now that could be because their brain is wired differently. It could be that part of that onset, which typically starts with the negative symptoms, they've stopped paying attention in class. They've stopped paying attention at home, right? They're not motivated. They don't have energy. So they're just sort of slowing down a little bit. It could also be like a brain chemistry thing. We don't know for sure. In terms of prevalence, it's quite rare. So 1 in 10,000 children is diagnosed with childhood onset schizophrenia. The diagnostic rate is 100 times higher in adults, okay? So that, just to give you a sense of how rare it is. It also tends to have earlier onset in boys than girls. Okay. In terms of causes and treatment, causes often tend to be biological, so they are genetically based. So oftentimes if we know that there is a family member with schizophrenia, we are more likely to see schizophrenia or other psychotic disorders in first-degree relatives than we would if in the absence of an identified family member with schizophrenia. But environmental factors can also play a part. So trauma, prenatal and postnatal environment and stress, and also family factors. So one of the things that's been studied is how families where there's someone who has schizophrenia, how they interact. And what we've seen is that in those families, there tends to be a higher rate of expressed emotion. And that's sort of very emotionally laden comments back and forth between family members. And it's unclear, it's a bit of a chicken and an egg thing. Is the family now expressing emotion at a higher rate because they have someone with schizophrenia in the family, or is the high rate of expressed emotion actually building into the child developing schizophrenia, right? We're not 100% clear because it is a correlation, not a causal relationship. But that can be a factor as well. And if you think back, you probably at some point in your psych career heard about the diathesis stress hypothesis. So we're all born with predispositions to different things, but they will only manifest under the correct or the right amount of stress, but what that is, we don't know. So basically it's when our capacity to deal with things is depleted, some of these disorders may manifest. And so that's where the environmental factors play a part also, because the environment influences how our genes respond to things, okay? In terms of treatment, well, medication is going to be an important part of treatment for most people with schizophrenia. The antipsychotic medications take care of a lot of the positive symptoms, so the hallucinations and the delusions. They have very minimal impact on the negative symptoms. So that's where supportive therapy comes into play to help a person with those absences. But medication is going to be an important part of treatment. In terms of the supportive part, oftentimes, especially with children, we'll have family treatment. We might also do some social skills training, so some of the similar social skills training that we do with children on the autism spectrum, as well as potentially some cognitive behavioral therapy for some of that executive functioning stuff, okay? So I now have 2 YouTube clips for you to watch. It's about 15 minutes in total. Please watch both of them before reading the updates below. So in both of these clips, you're going to be watching a young girl named Janie Schofield, and she has been diagnosed with childhood onset schizophrenia, and we're going to see some firsthand footage of her and her family, and then we're going to see an update from the initial footage. So go ahead, watch those, and then come back. And so now you're back. And now go ahead and read these and unlearn everything you just learned in the YouTube footage. What's interesting is both of these are relatively recent. So the article on The Verge was 2019. I believe Medium was about the same. And so for years and years and years, I've been showing these clips. I know I've talked to Nancy, who also teaches this course, and she's been showing these clips. And so when I found these updates, I went to Nancy's office. I'm like, did you? She's like, yeah, I know. I read them too. And we were both kind of crestfallen. So with that in mind, we have reflection question number 4. Ooh, surprise, 4 questions this time. How are you feeling about Janie and her family after watching the video clips and reading the updates? 1 paragraph, 6 sentences. And when you're done with that, that is the end of chapter 6.